Medicine. Case 4. A healthy 52-year-old man presents to the doctor's office complaining of increasing fatigue for the past 4 to 5 months. He exercises every day, but lately he has noticed becoming short of breath while jogging. He denies orthopnea, paroxysmal nocturnal dyspnea, PND, or swelling in his ankles. The patient reports occasional joint pain, for which he uses over-the-counter ibuprofen. He denies bowel changes, melena, or bright red blood per rectum, but he reports vague left-side abdominal pain for a few months off and on, not related to food intake. The patient denies fever, chills, nausea, or vomiting. He has lost a few pounds intentionally with diet and, on examination, he weighs 205 pounds, and he is febrile. There is slight pallor of the conjunctiva, skin, and palms. No lymphadenopathy is noted. Chest is clear to auscultation bilaterally. Examination of the cardiovascular system reveals a regular rate and rhythm, with no rub or gallop. There is a systolic ejection murmur. His abdomen is soft, non-tender, and without hepatosplenomegaly. Bowel sounds are present. He has no extremity edema, cyanosis, or clubbing. His peripheral pulses are palpable and symmetric. Hemoglobin level is 8.2 gdl. What is the most likely diagnosis? What is the next step in therapy? What are the considerations in this patient? Let's see the key points of this scenario. A healthy 52-year-old man complains of a 4 to 5 month history of increasing exercise intolerance, but he denies orthopnea, PND, edema, or other signs of heart failure. The patient uses a nonsteroidal anti-inflammatory drug regularly. He has not had any overt gastrointestinal (GI) blood loss. On examination, he weighs 205 pounds, and he has slight pallor of the conjunctiva, skin, and palms. He is anemic, with a hemoglobin level of 8.2 gram/deciliter. Most likely diagnosis: iron deficiency anemia as a result of chronic blood loss. Next step in therapy: analyze the complete blood count (CBC), particularly the mean corpuscular volume (MCV), to determine if the anemia is microcytic, normocytic, or macrocytic. Assess the leukocyte count and platelet count. Note the following for this patient. 1. Understand that iron deficiency anemia is the most common cause of anemia. 2. Know the diagnostic approach to anemia. 3. Be familiar with the treatment of iron deficiency anemia. Considerations: this 52-year-old man presents to the doctor's office with complaints of fatigue and dyspnea on exertion for the few months prior to the office visit. His physical examination is significant only for pallor. The serum hemoglobin level confirms anemia. The next step would be to characterize the anemia as microcytic, which would be consistent with iron deficiency, and confirmed with further testing for total iron binding capacity, TIBC, and ferritin. Other considerations: the most likely source of blood loss in male patients is the GI tract. Therefore, finding iron deficiency anemia should suggest the presence of a possible GI source of bleeding, with colon cancer the most serious possibility. This patient is using ibuprofen, which may predispose to erosive gastritis. Once iron deficiency anemia is confirmed, a thorough evaluation of the GI tract, including upper and lower endoscopy, is needed.